First of all, what is glucose-6-phosphate dehydrogenase? It is an enzyme which is active in almost all types of cells in the body which are involved in the breakdown of carbohydrates. This enzyme is involved in processing carbohydrates as well as playing a very crucial role in red blood cells, as it helps to prevent red blood cells from damage and premature destruction, known as hemolysis. This eventually prevents hemolytic anemia, which develops when red blood cells are destroyed faster than the body can replace them. The G6PD enzyme is essential in the pentose monophosphate shunt as it catalyzes the oxidation of glucose-6-phosphate and the reduction of NADP plus to NADPH. NADPH maintains glutathione, an antioxidant produced by our body in its reduced form. Reduced glutathione acts as a scavenger for reactive oxidative metabolites to protect the red blood cells from oxidative stress. The pentose monophosphate shunt is the only source for NADPH in red blood cells. Therefore, red blood cells depend solely on G6PD activity to generate NADPH. Hence, reduction in NADPH makes red blood cells more susceptible to oxidative stress than other cells, resulting in their premature breakdown when triggering factors are present.
What is the prevalence rate of G6PD deficiency? In the world today, it is estimated that 400 million people have G6PD deficiency with a high incidence rate, particularly in Africa, Asia, Middle East, and Mediterranean. Not only that, it is found that the geographic distribution of G6PD deficiency correlates strongly with the distribution of malaria. Several studies have indicated that G6PD deficiency can highly reduce the risk of one from having malaria infection, especially against severe malaria. In Malaysia, the prevalence of male G6PD deficiency was 6%, 4.6%, and 1.3% in the Chinese, Malays, and Indians respectively, but it is significantly lower in females at 1.7%, 1.4%, and 0.5% respectively. Studies show that a high prevalence rate of 9% is observed in the Negrito tribe of the Malaysian Orang Asli. Due to the high disease prevalence in Malaysia, G6PD deficiency screening is routinely performed in newborns. A higher prevalence rate is observed among Malays and Malaysian Chinese descent, while it is less common among Indians. The overall incidence of neonatal jaundice in Malay neonates with deficiency in G6PD is recorded at 82.6%, which is 71 out of 86 babies who undergo screening. The mode of inheritance. A mutation in the G6PD gene that is located at the XQ28 locus results in G6PD deficiency. G6PD deficiency is inherited in an X-linked recessive manner. Hence, G6PD deficiency is much more common in males who only have one X chromosome, while females have a lower risk of getting this disease due to the presence of two X chromosomes. Females with one X chromosome mutation are known as carriers and are usually unaffected. However, females can also be affected even if they only have one mutation in both copies of the G6PD gene due to the unfavorable condition in random X chromosome inactivation, where the normal X chromosome will undergo lionization and thus inactivated.
Now, I'm going to discuss the significant symptoms and some triggering factors of G6PD deficiency. The most significant symptoms include rapid heart rate, shortness of breath, fever, jaundice, paleness, enlarged spleen, and dark-colored urine. The development of symptoms requires the specific interaction of an alteration in the G6PD gene in combination with a specific environmental factor. The symptoms normally shown in newborns, but there are some who will develop symptoms only when they are exposed to certain foods, medications such as non-steroidal anti-inflammatory drugs, or infections that cause red blood cells to be destroyed prematurely. This will ultimately lead to hemolytic crisis. The exact degree of susceptibility to a drug varies from one person to another. Furthermore, G6PD deficiency symptoms tend to disappear within a period of time after the root cause is resolved. Only in rare cases, G6PD deficiency leads to chronic anemia regardless of exposure to triggers. The main food that should be avoided by G6PD deficient patients is fava beans, as it will lead to favisms. Favisms can cause an increase in the levels of reactive oxygen species due to vixin and convixins that are found in fava beans. These substances can trigger acute hemolytic anemia episodes in G6PD deficient patients.
Diagnosis of G6PD deficiency. G6PD can be tested by performing blood tests in order to test for the level of G6PD in blood. This is done through the use of quantitative spectrophotometric analysis, or commonly with the use of rapid fluorescent spot test to detect the generation of NADPH from NADP+. The results show positive if the blood spot fails to fluoresce under the ultraviolet light. However, the test for G6PD deficiency may be falsely negative for patients with acute hemolysis, as older erythrocytes that has a higher enzyme deficiency have been hemolyzed, while young erythrocytes and reticulocytes have normal or near normal enzyme activity. Other tests can also be done, such as bilirubin level and complete blood count, in order to determine the G6PD level. Also, G6PD deficiency is one of a group of congenital hemolytic anemias. Its diagnosis should be put under consideration for children with a family history of jaundice. The main treatment for G6PD deficiency is very simple. It is by removing the trigger or avoiding the oxidative stresses. Most infected individuals do not require treatments. Instead, it is managed by preventive measures. Individuals should be screened for G6PD deficiency before taking in certain drugs, such as certain antibiotics, anti-malarial drugs, and even other drugs that could trigger hemolysis. Furthermore, fava beans should be avoided for G6PD deficiency individuals. I hope this raises the awareness for G6PD deficiency in the world. Thank you.